second session, which is going to be a very important and a very relevant session on death on table. And Dr. Sangeeta Gupta, have you joined? Dr. Sangeeta Gupta? Yeah. So I welcome Dr. Sangeeta Gupta. She's founder secretary Delhi Gynecologist Forum 2000-2004 and has been vice president of Delhi Gynecologist Forum. I welcome Dr. Leena N Sreedhar, who is MD and head of the department OB/GY Manipal Hospital, Dwarka, and she's president of Delhi Gynecologist Forum, Dwarka. Dr. Sanjeevani Khanna ma'am, who is the founder president of Delhi Gynecologist Forum North. Dr. Renu Mishra, who has been the head of the department at Sitaram Bhartiya and currently president of Delhi Gynecologist Forum South. Dr. Jharna Barua, who is senior consultant OB/GY Kasturba Hospital, Delhi. And she has been faculty for MRCOG courses in RCOG North Zone. Dr. Kiran Chabbra, a great friend, and she has been vice president, and she is going to be the current president for the session, current 2 years of Delhi Gynecologist Forum West. Dr. Vandana, who's director OB/GY Fortis Hospital, Shalimar Bagh, and Sanjeevani Care, and vice gynecologist Forum North. So me and Dr. Arti Tandon, we welcome you all. And these slides have been very beautifully and very nicely presented and prepared by Dr. Arti herself. And Dr. Arti, please share the slides.
Yeah, I'm sharing. Are they visible?
Yeah, please
yeah.
Make it full screen. We will be talking a topic which is death of a patient due to PPH. I'll be asking questions from I'll be requesting my panelists to ask questions, and the expert comments finally will be given by our panelists as well as by Dr. Arti Tandon. So let us go to the concerns that we have. And friends, the most important concern when a death on table happens is breaking bad news to the patient and to the relatives. And this death may happen suddenly, and the times, as has been highlighted by the previous experts, the patients may be celebrating and they may not even know that the bad, some calamity has struck in the OP. Now, this can be a real damage to your reputation because, and as somebody highlighted, Dr. Rajurkar highlighted, everybody goes into shock. The patient is in shock, the doctor goes in shock. So, very important that and timely documentation has to be done. Let us talk about the various concerns. Now, the concern would be whether the documentation was timely, whether a police inquiry was there. We have a concern of mob violence. We have a concern of fear of litigation, legal issues such as complaint, arrest, court procedures, judgments, and penalties. And then following all this, we are looking at staring at exorbitant compensations and imprisonment. So I talked about the first case, I.K. Hari Prasad, son of K.V.A. Ramakrishna versus Tarapur Wala Nursing Home. Now, in this case, on 4th March 2024, the complainant, Mr. Prasad, stated that he admitted his wife to Tarapur Wala Nursing Home under Dr. Shiveen on August 10, 2013. Next day, his wife delivered a baby. Now, soon after, he was informed that his wife had suffered a massive and a hysterectomy was required. Now, the OP requested Mr. Prasad to get blood from the Sunshine Hospital. This took him 35 minutes to arrange for blood. Now, upon his return, the OP informed him that the patient's pulse was very low and weak, the blood was not used, and his wife was pronounced dead on the very same time and day. Now, the allegation of Mr. Prasad not give his wife necessary care by failing to control PPH. The hospital was ill-equipped to deal with emergencies, but did not transfer his wife to a corporate hospital despite being told that he was capable of dealing with the expenses. The defense, in the defense, the OP denied this negligence and stated that Mr. Prasad was not at the hospital at the time of delivery and blood was not made available by 9:30 a.m. The patient was not in a condition to be moved to another hospital, and antenatal record showed that blood grouping was done many months before her admission. So another defense that was done was that the OP recommended Sunshine Hospital to avoid complications. Now, nursing homes are not required to have an attached blood bank, and the hospital was fully equipped to deal with obstetric emergencies. Despite following a step-by-step PPH treatment, she suffered uncontrolled catastrophic PPH. And the final note by the commission was that the documents showed that the patient's blood pressure was low soon after delivery and it continued to fall. When this was the case, the OP should have reacted immediately. The OP did not explain why the measures shown in the literature provided by her to the commission regarding dealing with risk factors and bleeding were not followed by her for PPH management. Now, the commission noted that the commission sought to know that while PPH cannot be linked to medical negligence as implied by the OP, should they not be more cautious and expect complications during delivery? Now, the commission also stated that the OP neither explained the treatment given nor explained why surgical repair was not immediately sought. They further sought to know why the patient was not treated more aggressively. And finally, the judgment was that Telangana State Consumer Redressal Commission awarded 10 years, like after 10 years of this case was handled, awarded the hospital to pay 43,57,000 to the patient's husband and daughter. And the commission said that the hospital did not act swiftly and stated that nursing homes should be equipped to deal with eventualities instead of blaming the patient, while stating there was negligence and directing the OP to pay this much amount as compensation. The commission specified that half of this sum to be a fixed deposit in the name of the patient's daughter for her future use. So, the questions. Dr. Sangeeta, madam.
Name. What you want? You want me to raise questions?
Take up this question. Give your expert comment. Now, the question is that once a death of a patient has occurred, what are the immediate actions that should be taken before breaking this news to the attendants? I would seek your expert opinion, madam.
Okay. So before we are going to the relatives to give this information, everything is in order in operation theater, like all the things which are required for emergency services are available there, no expired drug is there, means and senior most doctor, senior most anesthetist and the whole team should be, जैसे कि आजकल हम मॉल्स में जाते हैं मॉर्निंग में उनकी अर्ली वो काउंसलिंग ड्रिल होती है कि बी टेल एवरीथिंग, so they should be told that what all we have to say to the relatives outside, and nobody and not all of the person who has been made the spokesperson or the senior consultant, he only will talk to the, he or she will only talk to the relatives, and there should be no conflict between the anesthetist and the gynecologist and the surgeons which we have called. They all should agree that what we are going to the, say the patient is not blaming game on each other, and we should decide inside only that what information has to be given. Then proper documentation has to be there. We should try to at least point wise write the timings of what was done, at what time, what happened at what time, what remedial measures were taken, and simultaneously the case sheet of the monitoring of the sister's record should also be very well be coinciding with the notes of the doctor. Right. Then we have to prevent from the mob violence, and as well as if there is a death, police has to be informed.
Right.
So, but we have to make the arrangements that police has to be informed, and I think these are the key points which we need to take care.
Dr. Arti.
Yeah, so ma'am, I'll just summarize this, that once such a death occurs, easier said than done, but please do not panic. Call for help and prime the IMA and FOXY. Call for the senior staff and colleagues if available. And as I said earlier also, the more the merrier, because you need a team to help you out. The anesthetist and the nursing staff and anybody who's there inside the OT to discuss the case, do not allow anybody to move out of the OT before you have had a discussion. Review the sequence of events. Discuss the case as to how the mishap occurred, why it occurred, what was the SOP, and whether you followed that SOP or not. Take the staff into confidence. Ensure that resuscitation was done as per the protocols. Call for the rush team or the support group who will help you to break the news also and stand by you in case of a mob violence. And do not think of transferring dead patient to the ICU or another hospital, as a number of consultants do that. They say that it is going to be easier to break the news to the patient once you transfer the patient to the ICU. But this is making you lose evidence, so the police can hold this against you. Then the entire staff should speak the same language, speak honestly without getting intimidated, and the doctor should decide what is to be spoken and what is not to be spoken, and should have her facts right, so that she doesn't fumble when the patient is asking you questions, a relative is asking you questions, that why did this happen. No loose statement should be given by any staff member, and the staff should be primed before breaking the bad news to the attendants.
Perfect. So the most important thing is that one person should be speaking, and that should be the captain of the ship, that is the consultant. And the staff should be on the same page as the consultant. Very well summarized. Dr. Leena, what evidences need to be preserved to justify that all efforts were made to save the patient? Your expert comments, please.
Yes, thank you, Dr. Shakuntla. When such a thing happens, it's very important that, like we just discussed, that everyone, the entire team, the surgeon, the anesthetist, the staff, everyone who's in the OT should be on the same platform.
Correct.
Your notes, your nursing notes, your OT notes, your anesthetist notes, the timelines should be all matching. There is something called retrospective notes which you are allowed to write because you were battling it, and the case is over. Now you sit down and you write the timelines. All these is your defense, is your evidence. What did you do? At what time were you called? At what time what measures did you take? Following which, when did the patient when was it wheeled into the OT? At what time the decision of say a hysterectomy was made, and what was the corroborating with the timelines and the resuscitative measures given by the anesthetist, and at what time did a cardiac arrest occurred, or what was the final event. That all has to match with your notes and the anesthetist notes. And all this evidence that needs to be preserved. That means your entire case sheet, because there is no point in saying that you called so-and-so person to help you out if it is not documented. So if you was attending to the case and you called another senior person, that person's name should be there. If you had an anesthetist who also called another intensivist, so that also should be mentioned. All these evidences are very important to justify that you made all your efforts to save the patient. And the timelines should be well recorded and kept in as a record. What I feel is that whenever such a case happens, while these records, like in the hospital I have, they are all put into it. So they capture the timelines. But in case you are having a written record, it's very important that the timelines are kept very much in in there, because that is very important. The time you took for each and every step that you took to try to save the patient.
So I will just summarize the talk.
Yeah.
That if the patient is gradually deteriorating, keep informing the relatives with a regular bulletin, and do not clear up the OT after death, as it will be considered as tampering with evidence. Check on the expiry of the expired ampules, if any, and whatever drug has been used and you are documenting, the empty ampules and the tablets need to be the cover of the tablets needs to be there. One member of the team should note down the events and the treatment given chronologically according to the standard operating protocols. Check the OT equipment that it is functioning. Save all the used materials, all the needles, all the threads, syringes. If the patient is still open, then check the mop and instrument count and close the patient. Do not remove the IV lines or catheter or the nasogastric tube. Ensure that they are in proper place. Crash cart with emergency medicine.
I think we have lost her.
Yeah, the slides I don't think were moving.
Yeah, yeah. So I'll just take over from there. What she meant was that all the things, the scenario where this kind of a problem happened, the death happened, everything has to be kept in place. Very well highlighted by you, Doctor. You summarized most of the things, but Dr. Arti was just adding finer details to that. Now, I think Dr. Sanjeevani has not joined. Madam Sanjeevani has not joined. There was a question posed on to her, that is that a prescription of certain life-saving emergency drugs was given to the attendants from the OT. Now, is this appropriate? Anybody can take up this question.
I think it is not at all appropriate, Dr. Shakuntla, because then patient is very valid to say in the court that they don't have anything to of emergency medicine. So this should not be done, but we should be in a habit to check up our routine emergency tray and see that all the drugs are changed as per the expiry date of the drugs also. It is so. This should be our responsibility. The person who is using the OT or the labor room and the one who is the captain of the ship, it is their own responsibility, and there should be a checklist which daily the labor room staff, this is what the Lakshya protocol tells us. Absolutely. That how to take care of your cesarean emergency OT. So we all have to follow those Lakshya protocol where checklists are there for everything in a labor OT.
This is given in Manyata protocols also, Lakshya protocols and Manyata protocols.
Can I just say, it is not just for PPH, it is for any kind of emergency. If you do not have emergency drugs, you are not supposed to function. You cannot take any
even when you are taking an ambulance, to any place, then you have to have a checklist for all the drugs and all the equipments that are required for transporting the patient. That is also important.
You have to have the emergency drugs in the ambulance, plus a person who knows how to use them. Correct. Not just and actually the handover should be given by that doctor at the time when the patient is taken over by the team in the receiving hospital.
And the team should know what is lying where. What is lying where, that is also very important, because then the important time is saved, in doing that. Madam Renu Mishra, we are all aware that imprecise and incomplete documents can create difficulties for the practitioner. Now, what details should one ensure to have infallible records? I think Dr. Arti has joined again. We are going to the question to Dr. Renu, madam. So, my question was, what details should one ensure to have infallible records? To you, Dr. Renu.
I think we've already sort of covered this, but basically the drugs which are administered with, of course, the timeline and whatever procedures which are done in. Sometimes it happens when a patient is really bleeding. You do not have time to write all that. Somebody if you have an extra person, at least make that person jot down on a piece of paper that, you know, this has happened at this time before you put it in final records.
Right.
Because in the final records, if you try and put it at that time, and then you like to change something, it will be tampering of records, and those records will not be acceptable by court. So rather than trying to put it in the final records at that point of time where there is so much of chaos, if a patient is dying, let somebody just put some rough notes, put the timeline, keep writing the drugs, misoprostol, prostaglandin, and then you've done maybe laparotomy, you've done internal, whatever. Just write it down so that you then have a reference to write the detailed notes afterwards.
Right. Dr. Arti, do you have to add?
This, can I say something? Can I
Yeah,
just
please,
add
please,
something?
please, please.
So we have a circulating nurse who's always there, you know, in the OT. So whenever we have, you know, a PPH, or for that matter, for us it's PPH always as a commonest emergency. The circulating nurse is the one who keeps adding on, you know, what was given when. So that's another way we can, like what Dr. Renu was mentioning, that someone is there who's roughly noting down what was given when. So that later on, when you sit down to write your retrospective notes, you have all the timelines just in front of you and you don't forget anything.
Correct.
Because otherwise, later on, when you start writing, you honestly cannot remember what
Exactly,
हाथ
exactly.
पांव
Like
फूले होते
Dr.
हैं मैडम उस
Kishore
समय.
said, you are like Dr. Kishore just now said, you're so
I know,
traumatized
हमें
yourself.
अपनी emergency drug लेने की हालत होती है, तो obviously you can't.
Bilkul.
Correct. So, have you lost Dr. Arti, or are you there? My next question is to Dr. Jharna Barua.
I'll share one thing here, you know,
Please.
that, you know,
please,
more
ma'am.
than the drugs are important. People will remember. We say that we do not remember. We remember as everything as far the drugs are concerned. But I think, you know, the nurses are very sharp. So अगर आपके vitals nurses के vitals से नहीं मिले तो आप you've had it.
Correct.
Yes.
But मैम उस समय तो वो नर्स ही चार्ट करेगी, हम तो बाद में ही लिख पाएंगे.
ठीक है, तो what I'm trying to, जो नर्स ने लिखा हुआ है ना, वही आपको लिखना होगा. उसने 70 लिखा और आप लिखो 100/70 तो नहीं हो पाएगा.
बिल्कुल.
So as Dr. Jharna, I have a question. Sorry, Dr. Arti, please.
I just wanted to add two things that ensure that the consent form, pre-operative investigations, and the PSC are well kept in such situations. And as I said, this has already been said. And if any modification is made, it should be signed. Then numbered, each page should contain the stamp of the hospital and the signature of the treating doctor. Total number of the pages should be documented at the start of the file. And in case the relatives put away the file an FIR.
Right. So this is the question for you, Dr. Jharna, madam. What does the court see when examining the documents of the patient?
Yeah, so the court actually sees whether you have followed the protocol. Whenever it sees first the consent form is there or not, and in case you have done an emergency is important. Patient cannot obviously give the consent of the relatives should be there, and it will start from the antenatal records, whether you have seen the patient properly, whether the care, if he was a high-risk patient, whether her care was written in the antenatal records and whether the patient was explained or not. Because if you land up in a hysterectomy in anemic patient, that means that you have not taken care of for that patient in the antenatal listing. Then all the records that, supposing this patient has PPH, the court will want to know whether you have documented it properly. And the best thing is to go through a checklist, because you might miss out something. If you go through a checklist, you do it in a systematic order. The first thing, whether you have given oxytocin. The second thing, when oxytocin have failed, what you have done. And third, fourth, every point should be there. Most important is, when have you attended the patient? The time should be there, documented. What time you have actually attended the patient? Was there any lapse between you being called, a consultant being called, and a junior person calling you? Everything has to be documented, and the time lapse should not be more. And whether that golden hour was taken care of, blood was arranged or not, everything. I mean, the protocol which has to be there, the SOP has to be followed in detail. That is what they want, whether you have followed the SOP properly or not. And this is what they basically examine. And whenever they ask for an opinion from outside, they basically want to see whether you have adhered to the protocol or not. I would just like to give you one example of what happened in our hospital, and which was a nightmare. It just happened that one patient, she was just 19 years old. She came post-dated in a post-dated pregnancy with a 3.5 kg baby, and it was an IUD. She came post-dated. And people are of the notion that IUD means should be delivered vaginally. That patient had a prolonged labor. She delivered vaginally but had massive PPH and had to undergo an emergency hysterectomy. After that, she went to court. She made her life hell. She wanted all the doctors involved in her care to be transferred. That was her only this thing. And all the doctors were transferred. So, and the second thing she asked is, you have to bear the money for my surrogacy, and ultimately she was divorced by her husband. So that was the second thing. But the one thing that she demanded was all the doctors involved in her care, her PGs, everybody should be transferred. So all these things, before you actually go for a hysterectomy, you should take I mean, what I want to say by this is, you have to, even if it's a dead baby, you have to take an early recourse if there's a prolonged labor. And regarding other documents which the court would like to see is, I think this is what it wants to see, whether you have followed the SOP or not, and whether you have involved your consultant, whether you have called for help, whether in cases of placenta prurita, whether all the specialties were involved or not. And this is basically the protocol is whatever is there, whether you follow the protocol or not.
Yeah. So I'll just
Dr. Arti, yeah.
That any visible tampering, if you have done any kind of a visible tampering in the notes, or any overwriting, or any use of white ink to perfect a document which shows that yes, you've opened up a textbook and then written it, whether the consent was valid or not. More than one set of files. There was a case where the anesthetist and the gynecologist both submitted in the court the original set of files. So this was considered as forgery, and both of them were penalized. And contradictory notes. And the absence of proper medical record shall be presumed to be negligence.
Right. So the file has been made, and the court found some additions and deletions as just highlighted. And in the existing records, it was proved that some addition and deletion was done. Dr. Kiran, what are the legal implications of such a thing that happens? Please.
So even if the doctor has documented everything, and she has she has written her interpretations, or she has cancelled and written the interpretations, then it will go always against the doctor. It will never be like that. Court will say, no, you had something later on, you have understood it like that. So court will always take into against the doctor in such cases. So we have to be very, very careful while documenting our findings. As we all have discussed and said that whatever we are doing, we should document properly at every step, with the time, with the consent, whatever we are explaining, whatever calls we are giving to the anesthetist or to the senior doctor, or we are calling for help, everything should be mentioned very, very clearly, without tampering with, or without overwriting, or without cancelling and then writing, because it will always go against the doctor.
Okay.
Dr. Arti.
Yeah, so to summarize, whenever we are making any changes, once we've received a legal notice, then it holds absolutely no legal value. So never erase or use a whitener. Changes made in the existing file after receiving a legal notice is considered as cheating and fraud. Using a different pen or handwriting is also considered deceitful. Notes of other doctors who have seen the patients should be put forth without any change, and the notes of all the doctors need to concur. And never alter the records, as it leads to loss of credibility.
Can I just add?
Please.
If you have to change something, then rather than trying to erase it, just neatly cancel it, sign it, and write it.
No, but this needs to be done before a legal notice has been received.
Absolutely. No,
Yeah.
when you're making
Yes.
writing the notes, suppose something by mistake, you could just neatly cut it. Don't try and sort of smudge it. Just neatly cut it, sign it, and write it.
Double sign it, yeah.
Because we really do not know, but the patient usually always has a copy of the file before he goes to court.
No,
And we are making
Dr.
changes in
Not
that.
after.
Yeah.
Dr.
And
Arti,
also
I
the
just wanted
RMO
to
resident doctor was implicated for this also when she cancelled and she wrote something. जैसे कई बार हम करते हैं ना, लिखते लिखते काट दिया और फिर उसको दोबारा लिखा, तो वो भी उसके अगेंस्ट गया.
नहीं तो वो नीटली अगर
Dr.
काट
Arti,
करे.
I fully agree, Dr. Renu, with you.
I have a small question, Dr. Arti.
Yeah.
So for the last 6 years, we've been doing all our records are digital, so we can edit them. Now,
See, the
same
minute-
thing will apply. That means to say that whatever editing we want to do, we do it right after the incident, and that's it.
Ma'am, it is whenever you are doing it on a digital platform, it is the easiest to find that you have tampered. Because when you are putting it on a digital platform, it is already dating and timing your notes.
Yes, and any editing shows up.
And anything that you are changing is going to show up. So it is the most dangerous thing that can be done, that you try and change the digital notes.
Yeah. So for what is your advice? Yeah, so what is your advice?
Ideally, before the patient is discharged or immediately after the patient is discharged, you should go through your files and write down whatever needs to be done at that time.
Right. I think that is, for all of us, I think that is a very important thing.
So,
मैम होता नहीं है ना, when we are writing, दिमाग में कुछ और चल रहा होता है, आप लिख कुछ और रहे होते हो, फिर लगता है अरे गलत हो गया, आपने काटा फिर, और वो अगर कोर्ट में तो आप क्या?
नहीं, उसको डेट एंड साइन कर दीजिए फिर उसी जगह पर.
ओके.
और वो आपका ओरिजिनल होना चाहिए, उसको दोबारा से करने की कोशिश मत करिए, you know, that is important.
और उसको ऐसे मत काटिए कि वो दिखे नहीं, उसको छुपाने की कोशिश नहीं करें, उसको नीटली एक लाइन क्रॉस करें और साइन कर दें.
Date time.
Can I make a comment?
Sir, please.
See, in digital records, there is mostly provision for addendum. You can always put a revised comment or opinion in addendum. So that is acceptable. Secondly, even during the course of treatment and care, the patient's family members often have a tendency to take photographs of the medical records. So it's a bit dangerous to amend the records even before the legal notices come or before the patient has had a cause to complain.
Because sir, the patient will go to court only once they have the records. So they usually bribe somebody or the other and have the records.
No, see, many times they come for a visit to the patient and they find the file there, or they might ask the nurse एक बार file दिखाना, तो देखते देखते वो mobile से photo ले लेते हैं. I know of a couple of cases where this kind of a problem happened. The nurse had written the temperature 92 degrees in a patient 2-3 times. The attendant has taken the photographs. He talked to the doctor and he said the 92 to ho hi nahi sakta. You're lying and all that. And they changed the record, the nursing records, and produced the court. And this complainant produced that sheet also, which was missing from the records obtained from the hospital. So we should keep it in mind that they have a facility of taking a photograph records.
Thank you, sir. Thank you very much. Moving on, Dr. Vandana is joined. So anybody can take this question. The impending signs of violence, you know, once the death has occurred. So what are the impending signs and how do you detect it? You know, so who can take it? Or Dr. Arti, your comment?
Yeah, Dr. Shakuntla, I will tell this, that the warning signs of an impending violent reaction has been summarized in a stamp approach.
Okay.
S stands for staring. The patient, relative, or the patient, you will find them staring at you. T
Okay.
is the tone and volume of the voice, that they'll start yelling, there'll be sarcastic comments, and there'll be caustic replies. A is anxiety. This will be evident. M is mumbling. This normally reflects the frustration. And P is pacing. symbol of agitation. So the minute you see this, you have to be very wary of mob violence.
Okay. So as soon as the death is declared, there is a good crowd of large number of people that are gathered outside. Now, Madam Sangeeta, what are the precautions that we will be taking as a practitioner to save from this mob violence?
As very well said, that we have to call our association people with us, like we have to inform our local organization like Delhi Gynecologist Forum में अगर हमने कुछ ऐसा बना रखा, we should call them, we should inform DMA, IMA, we should inform whatever the local persons, and then we should, first of all, we should inform a hospital in charge person that such and such thing has happened in the OT and you kindly be around with us. Then the hospital administrations should be there. Then again I said there should be a medical legal MLC should be there, and we should have a back gate to prevent from that violence, that we should not go directly in front of the agitating people. Only 1 or 2% should be going there, not all of them, not all of us should be there, and they should be called for a decent counseling. हमको उन सबको बुलाया and take them to a room where everything is being video recorded or whatever, that what has happened we should tell them exactly. So I think violence is very difficult to deal with, but only with the patience and proper taking help of your administrators and your local organization bodies. You can
Right. Yes, Dr. Kiran.
Small nursing homes do not have administrators. So inform the police station, the police chowki close to you.
Yes, Dr. Kiran.
As we are working very also in corporate also, in our into some zones, and according to the zones we have made WhatsApp groups.
We have those groups. Right.
Like zone 1, zone 2, and we have made 4 doctors in charge of that. So whenever there is any emergency of such kind which happens in the nursing home, whether with the patient or the child, like a neonate or somebody else, that nursing home owner staff can give a call on that WhatsApp group, and more doctors collect. And this we have gone through many times in our nearby areas. So many people collect there, and first the mob away from that, from the doctor who is in charge.
Yes. Your point very well taken.
Can I add one thing?
Yes,
I
please.
think the CCTV recording should be always there.
Yes.
Right. Correct.
So I'll just summarize that.
Yes.
Always inform the MS of the hospital, call for the security, call the police. This is most important. Ensure there's an emergency exit, call for the rush team. Always inform the police and document when the police has been informed, and obtain a written acknowledgement. In case you have given the information telephonically, record the name and designation of the police person, and the police will make a panchna.
Right.
CCTV cameras must be installed and must be functional. And if the patient has been referred by another doctor, call him to be there with you when you break the news. Then emergency exit should be outlined, and restrict the entry of relatives and the media. Depute someone to immediately get the medical record of the patient photocopied, and get written signed statements from the persons present, whether doctor, staff, patient, relatives, others, regarding the occurrence of violence, so that it can later be used as documentary evidence against them.
Right. Very well.
And one thing more, that in these scenarios, sometimes they snatch the original case sheet from you.
Yeah,
It
so you have to
happens.
file in.
That has to be documented. Yes.
That has to be documented, and you cannot.
Police has to be told about it.
And police, because this has happened in our hospital, that original case sheet the relative leke, he just ran off with the case sheet, and we have to make a duplicate case sheet, and from the CMO, from that point onwards, we wrote the original notes, and later on, whatever we remembered, and as per the sister's note, we wrote that it is a duplicate case sheet, and So one has to be very careful about the case sheet, that it should
Right,
not
right,
be
right.
forcefully taken up by the relatives.
Right. So, Dr. Leena, the doctor was brutally beaten and the furniture was broken. So now the FIR was requested. Can the police arrest these vandals who had done the?
Absolutely.
Yeah.
Absolutely. There is a law, and it has to be put up in every hospital, nursing home. We have that placed very
Poster,
clearly.
yeah, yeah. There is a
Poster
poster.
that, any kind of physical violence, of damage to property, all that is, the person would be arrested for that, and I think it should be put in a very prominent place and very clearly pointed out.
Right, right.
Yeah.
So anything you
So
have to
this-
add, Dr. Arti?
Yes, yes. So in case of violence or destruction, register an FIR under Medical Service Persons and Medicare Service Institutions Act of 2008, and this is basically of Delhi also, and it is cognizable, non-bailable and compoundable. And proof of destruction of the property has to be there. So you have to file an institutional FIR, and witness of the violence should be accounted for.
How many FIRs we should file?
You can file any number of FIRs. One is in case the somebody has snatched the file. This I've already mentioned before. That in case
Separately.
somebody snatches, yeah, you will file. And in case, because this is a different thing, that you have been beaten black and blue, so you
Yeah.
have to, yeah.
So anybody can take this, and Dr. Arti, your comments on how do we inform and when should we inform the insurance company once DOT has happened? What is the right time?
Should I answer?
Yeah, please.
Okay. So in case, immediately inform the insurance company with whom you are indemnified, and especially after a mishap or death of a patient where you are expecting a case to be filed. You've not yet got a notice, but you are still expecting a case to be filed. You should inform your company. On receiving a legal notice from either the advocate or the consumer court, in case of a disgruntled patient, if the patient or relatives resort to violence, and when the doctor has been found negligent and compensation has been awarded to the patient.
Because timely
So these
information
are-
is important for getting the indemnity people getting activated. If we
Yes.
don't timely inform, they can always raise an objection and they may not fight your case. So that is something very important and
Yeah.
very this thing aptly raised. Now, Renu, what are specific aspects will the professional indemnity cover when such a case has happened? Death on table.
I'm not very sure, but what I think that if you have been proven to be criminally negligent, then the insurance company will not cover you.
Agreed. Yes.
Yes.
So, Dr. Arti,
So I'll just summarize this. Yeah. Any extent of financial damage or loss to the victim, which is not a result of willful neglect. You've not deliberately done this neglect. Then unintentional errors and omissions will be covered under professional indemnity. In case your unqualified employees have been insured by paying an extra 7.4% to the company, then your unqualified employees will also defending oneself in the court of law. So these are the things that the professional indemnity covers.
all right. These are very important points. I think I would like this slide to be shared in the group. Now, Dr. Jharna, what is the relevance of,
I'll do that.
Yeah, please. So what is the relevance of postmortem in such cases? And suppose the attendants refuse the postmortem. So what is the relevance of these two situations and what should we do?
Okay, so if you are not sure of the cause of death,
Right.
then you always ask for a postmortem to be done.
Right.
And if the relatives agree, it's all fine. If they do not agree, take the writing from the relative that they do not want a postmortem.
Correct. Right.
Yeah.
So I think
So
that
this
covers.
always insist. Yeah, always insist. And the main thing is that even if you are sure about the
Sure
cause
of death.
Yeah.
go ahead and advise
Very
postmortem
important.
examination, as it shifts the burden of proving the same. So ultimately, there's going to be somebody else who's going to speak your language. So
Right.
allow it to go for the postmortem.
May I make a comment, please?
Yes, sir.
See, DOT by and large is taken as medical legal
MLC.
unless there is a very apparent cause of death available and there is no dispute between the patient and the caregivers.
Right.
For all MLC cases, autopsy is mandatory, and we have no right to condone or waive off the autopsy. The police can; they have their guidelines. They can. So, in all cases of DOT, at least, we should advise autopsy, and in a manner of saying, tell them that this is a part of the law, and the police can waive off the autopsy if required. Secondly, in all hospital deaths, whether they are DOT or the ICU or the wards, in all hospital deaths, when we are doing that grief counseling after the death or breaking the bad news, we should make the attendants seated in the room, make them comfortable, be sensitive with that, and during that counseling session, also touch upon the issue of autopsy. You can always say that these are the possible causes of death in this patient, but I'm not sure, and I would like to know what exactly has led to this eventuality. And there is a fair chance that they might, as a first reaction, say that we don't want any autopsy. Then you can ask them again that I would like to get it done, but if you're not willing to get it done, please give a refusal.
Yeah.
So
Right.
you'll have a refusal consent there.
Right. Thank you, sir. Thank you very much. Dr. Kiran, now the dead
Sir,
body
sometime, even they are not ready to give a refusal consent, then you must call the police and you say that, you want postmortem. Let them then take a decision.
Right.
हाँ मैडम, हम लोग सर सब लोग basically we are afraid of getting the postmortem done. So we should be out of this dilemma, and we should rather going for postmortem.
It is in your favor.
Yeah, we should all be inclined to get it done.
So last few questions. Dr. Kiran, the patient doesn't want to, the attendants don't want to pay the bill, and the hospital is refusing to hand over the body. Now, what do you think? What is this situation, and is it legal to withhold the body and not hand it over to the attendants because they have not paid the bill?
Legally, I think it is hospital can withhold the body. They can at that time humanitarian ground पे वो patient को भेज सकते और बाद they can get back. But normally I don't have much. But as far as
डॉक्टर किरण आपकी वॉइस ब्रेक कर रही है.
आप withhold नहीं कर सकते body को. Legally, I think we cannot withhold the body if the patients do not pay the bill.
Right.
Humanitarian grounds पे भी आप उसको उस सिचुएशन ऐसी होती है, अगर आप पैसे के लिए बहुत उनसे जिद करोगे तो probably they will get more offended. You can be on their side and feel कि आपके साथ जो हुआ वो अच्छा नहीं हुआ, आप पेमेंट बाद में कर देना, आराम से कर देना, इस तरह से बात करके आपको बॉडी तो देनी ही पड़ेगी.
So in Consumer Education and Research Center versus Union of India, this was a case where it was clearly stated that this is considered as illegal, squarely inhuman. These are the words which have been used. And in 2018, the National Human Rights Commission also published a draft charter stating the same. And the Supreme Court also in 2018 said that notices will be sent to hospitals and doctors if such a case came to light. So we have to
let go the money.
Right.
That's why they take advance payment these days.
Dr. Arti, take up this question also.
Still you cannot full advance payment.
So the patient can
also under what forums can the complaints be filed by the patient?
So the practitioner, so a patient can go to the professional regulatory body, can file a case against you in consumer or the civil court, can go to criminal court, can go to Human Rights Commission, to any government authority, can write a letter to the Prime Minister or the President, and can also do all of this simultaneously.
Okay.
So it is all open for the patient to go and sue the doctor at any forum.
So, Dr. Sangeeta, now can the patient sue a doctor under 304A and request for an arrest? And should we take an anticipatory bail in such a case where death on table has happened?
No, not these days. With the latest regulations, doctor cannot be sued under 304A.
Okay.
Dr. Arti has to tell me in details.
No,
because
in today's date, it is very, very open that a doctor can be sued under 304A, and there is nothing that you cannot have a criminal complaint against you. But the guidelines of Jacob Matthews give us some rights. That is that no private complaint unless there's a prima facie evidence from the expert. Then there is a protection which we get, that the police FIR only after expert opinion, preferably unbiased from a medical practitioner of a government hospital who gives the result in accordance with the Bolam's test. And the privilege we have is that a doctor cannot be arrested like any other normal person. For example, for any other problem, if somebody else is arrested, but a doctor will not be arrested in that manner. And 304 is still there where a doctor can be arrested. And a doctor can be arrested in case the doctor is not cooperating in the investigation, or it is required for the collection of evidence, and when the doctor is hiding, and when they presume that you can flee from the scene. And section 304 is a bailable offense. So bail can be obtained even in the police station after paying a certain prescribed amount. So no requirement of an anticipatory bail.
All right. Now, it sounds very gory actually, because it's the reputation of a doctor that is at stake. So, Dr. Leena, what are the defenses that a doctor can take in such a situation where there is a looming risk of arrest?
That is a little tricky. What defenses that we can take?
Dr. Arti,
I think, so I think, whatever we are practicing, first of all, been talking all this time, taking proper consent, doing proper documentation. Whenever such a calamity happens to us, making sure that the timelines are done. These are what will help us in our favor. And these are the defenses which I feel a doctor should take in their, should make it a sort of for each and every case can be a potential litigant. That is what we must think, and we must work to now work as a doctor.
Right.
But I would
just
love to hear what Dr. Arti has to say.
Yeah. Actually, the defense has to be decided whenever you are giving the papers in the first place, because the defense cannot be changed even once you are doing an appeal in a higher court. So the common defenses which are used is that of contributory negligence. When the doctor says that, no, I was not the only person who was negligent, the patient was also negligent. And for example, he's not taken his medicines, or he has not come for a follow-up, or that he's gone for a second opinion, he's not followed a diabetic diet which I told him to have. So all these will come under contributory negligence. The patient does not lose his entire claim, but gets a reduced compensation, which is according to his share of negligence which has occurred. The second is that there was an error of judgment, which means that, or diagnosis, that there was a misdiagnosis or a wrong diagnosis or a delayed diagnosis. The third is an accepted practice, that when there are two schools of thought, when there are two routes for treating a patient, then if you're going through one set of treatment, then you will not be considered guilty. So a doctor is not guilty of negligence if he has acted in accordance with a practice which is accepted as proper by a responsible body of medical men skilled in that particular art. So if the experts in your field say that no, this is an accepted practice, we agree with it. So then this will be agreed on, and this is called also as a Bolam step. Then the fourth defense which can be taken is that I had taken informed consent. I had explained everything to the patient, and the patient went ahead with this kind of a surgery or this kind of a treatment, fully knowing. Then that it was a work accident, that an accident took place, and that the thing was done in good faith. For example, a hysterectomy was done to save the life of the patient. So this act was done in good faith. So these are the kinds of defenses that a doctor can take while filing his papers.
Dr. Arti, 304A,
Yeah.
if the doctor has been arrested, what is the maximum punishment he can get if the cases are proved against him?
No, okay. There's one more question. Can I just answer it before we go?
Yeah, strategies. Yeah.
Yeah, strategies for safety of doctors. I will answer that. Number one is that an informed consent has been taken after informing the patient. Number two is that a doctor should have a genuine qualification and the skill and experience that he is trying to portray. Then records of important bills, oxygen cylinders, refilling dates and bills, equipment maintenance, date of sterilization of OT, they all need to be preserved. Adequate professional indemnity insurance has to be taken, and a basic medical legal knowledge is very, very important for safeguarding oneself. The WHO protocol, I've already said in my talk, that needs to be carried out. The use has to be known, and this checklist has to be filled in such a situation. Yeah.
Right.
So,
this is the last question to Dr. Renu. What is the maximum punishment imposed upon a doctor under section 304A of IPC if such a thing happens and the doctor is arrested? Last question.
I think it should be the same as in anybody, because if it is proven 304A death, not premeditated murder, but that you have caused death, so it is the same as for anybody else. No difference for the doctor as far as
Dr. Arti?
Yeah. So 304A is basically death of a patient due to rash or negligent act, not amounting to culpable homicide. So you don't have a guilty mind, right? So, and this shall be punished with imprisonment of 2 years, or with fine, or with both. Now, this is a cognizable and a bailable offense and is tried by a magistrate first class. Now, what I needed to add is that since from July, we are going to have a Bharatiya Nyaya Samhita. And over here, there is a section 106, which is going to replace 304A. So you see how it has been written that the rest of the people will be punished with 5 years, but a registered medical practitioner will be punished with imprisonment of either description for a term which may extend to 2 years and shall also be liable to fine. So number one, we have come in the eyes of people that yes, a doctor is also imputable under law, that you can also be penalized. This was not there in 304A. No word, no mention of a registered medical practitioner was there in 304A. But in 106, this has come, trying to ensure and emphasize that you are equally gullible to be punished. The second aspect which I wanted to put across was that I'll just go back to 304A. Here it was 2 years or with fine, OR, or with fine, or with both. But in 106, it is extended to 2 years and shall also be liable to fine. And the liable word is that it is at the discretion of the court. So the things have become tougher for a doctor with section 106 of Bharatiya Nyaya Samhita, and rather than the Indian Penal Code.
So we are at the end of our panel discussion, and I think the show was stolen by Dr. Arti and all our expert panelists. So, any final comments by anybody, and we'll wind up.
I just want to say one thing, that PPH is padas padas bane Hanuman.